Hello, everyone. A very warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. Before I continue, I want to acknowledge the Ngunnawal and Ngambri people who are the traditional owners of the land where ANU is located. And this is the land where we will be broadcasting to you from. I would like to pay my respects to the elders, both past and present. I would also like to acknowledge our sponsor, which is the National Capital Private Hospital here in Canberra. Now, we're very pleased to welcome attendees from various parts of Australia, as well as around the globe, including places like India, Indonesia, Burma, just to name a few. We know that knowledge is power, and we hope that through our weekly webinar series, it will help us to share our experience and expertise so we can learn from one another, which is especially crucial during the pandemic. Now, today we are delighted to have with us a team of experts who have dealt with not only working with information technology, but importantly, using this to help optimize healthcare systems and to help improve patient access to care. Before I talk more about our speakers, I just want to introduce myself and my team. So I am Evangeline, a medical student and a volunteer for the ANU COVID-19 Peer Support Program. Joining me are my colleagues. We have Bridget Nielsen and Dia, who are both medical student volunteers. And we have Dr. Dipti Talalika, who is a clinical hematologist and the program lead for the ANU COVID-19 Peer Support Program. I just want to tell our attendees about a couple of housekeeping notes. So I ask for all attendees to have their video and microphones switched off. This is to ensure that the sound quality is clear and helps to reduce any interference during the webinar. I would encourage attendees to ask questions and share their inputs, and you can do so by using the Q&A button, which is located at the bottom of your screen. There is an option to submit your questions anonymously, so you can do that if you wish. Another thing is we'll be launching a poll towards the end of this session, and I would ask for all of us to please submit a response. It will be very helpful. Please also note that if you're having any technical issues or any questions, please feel free to email us using this address here. And finally, please note that this forum is being recorded. On to our webinar today. Today's webinar will be primarily delivered by Raj Janaparadhi, David Olmos, and Shalendra Kumar. And the topic will be on IT and health technology innovations for COVID and beyond. I don't know about you, but for me personally, I'm looking forward to today's webinar because I think it is an especially important topic as technology is at its best when it brings people together to help achieve a caring healthcare system for our community. And in the current atmosphere where the pandemic has brought about a lot of disruption to our healthcare system, to the point where certain parts of our population are not able to access adequate care, I really look forward to learning from our experts on how we can use our devices to bridge the divisiveness that this pandemic has brought about. So joining us are our three speakers, and joining them will also be a group of panelists, which include Atul, Dr. Vijay, Rajesh, Amit, and Rama. And together, there will be a panel discussion on the second half of this session, and they will have a discussion revolving around practical issues. So we will hear inputs from an IT provider's perspective, from a medical professional's perspective, as well as from a patient's perspective as well. So thank you so much for all of our speakers for joining us today, and I'll hand over my time to Shailendra. Shailendra, just so that you know, you're on mute at the moment.
Yeah, I just unmuted myself. Thank you for that. Thank you, Evangeline. Hello, everybody. Great to be here. Just let me start sharing my screen for a second. Can everybody see my screen?
Yes, we can. Thank you.
Yes, we can.
So my name is Shailendra. As Evangeline has already pointed out, I'm going to be helping out in running this show. We are here with Raj and David, who are the key speakers for this event, and then we have a set of panelists. Let's have a look. We have already seen that. Let's have a look at the agenda for today. We'll have a quick opening introduction to the panelists, and then Raj, David, and myself will spend some time talking about the healthcare IT, how it has evolved over the years. What has happened, what are the key changes in the COVID times, and how it is likely to shape up in the next few years. We'll spend some time raising some fundamental questions, fundamental thoughts around what has been happening. And then after that, we'll take two case studies. One is the Helfa one that Raj will present, and another one is the Q crash, which David and I will present. After that, we'll have a panel discussion wherein all will participate, and then we'll close this session. That's the plan more or less for the day. Please feel free in any of these talks. If anybody has any questions, please feel free to ask your questions at any point of time. Although we'll have a question and answer session towards the end of the session. Again, Evangeline, you've already shown these photographs. I'm just showing it once again. We've got Atul, Dr. Vijay, Amit, and Rajesh, and Rama as panelists. Rama is still struggling to join. I think she'll be joining any minute. And then we've got Raj, David, and myself. That is the core speakers and panelists. And then we've got a set of audiences in the background. So let's start the session. The tech sector in healthcare, it has changed dramatically over the years, especially in the last 2 years as we have been facing this pandemic. The changes have been pretty rapid, and there are a lot of new things coming up. Raj is going to tell us about what it has been like in the last few years. Where have we started from? What was the core focus some time back? How it has changed over the period, and how it is looking like now. I think that is going to be a very interesting talk. I'm just going to hand it over to Raj with the next slide. Raj.
Excellent. Thank you so much, Shailendra, for the kind introduction. Dr. Deepti and ANU team, thank you for giving us the opportunity perspective. This topic is very close to my heart, and then working in IT, I think there hasn't been a better time than this, where the world is changing so rapidly and so uh, disruptively. So let me just put it in perspective as to what it means. What is the content and what is the context and what do words mean for us? RPM. You know, if I ask a mechanical engineer or anyone, Amit or somebody, they would say it's revolutions or rotations per minute. But this whole term of RPM has completely changed in the last 1 year. It's remote patient monitoring. Now, when I talk about a word called scrub in the medical fraternity, Dr. Deepthi, Vijay and all, Dr. Vijay will say that, you know, it is just getting ready to before the procedure in the ICU or before a procedure in the operation theater. And if I ask the same thing, scrub to my daughter or my niece, they would say it's a face scrub to do some, you know, fragrance peeling or something. And while the picture of the scrub, what you see, the OT dress, is it relevant? We will see in the coming things. Da Vinci, we would relate it to Leonardo and the Mona Lisa. But the medical fraternity, Da Vinci would be totally different. It take us to the different context. Shalendra, can we switch to the next one, please? So just keep this in mind and look at this. If you see at the bottom half and the first one, you see there is a surgeon who is working. Probably the surgeon is in Paris and the surgery is taking place in Ontario or India or in Delhi or Singapore. And the surgeon is put his head into the Da Vinci robotic surgery equipment. And do you see something very strange and funny? If the surgeon is in Australia and doing the surgery in Canada, do they need to really scrub? Right? And another picture will give you a glimpse of this one. That's a EICU, an electronic ICU. ICUs of the present and the ICUs of the future will be like. I don't think we have to be surprised what has happened to the healthcare industry in the last 1 year. It was a brick and mortar industry where people had to go in person. But today, if you ask what has happened to the healthcare industry, it has changed from bricks to click. You don't have to physically go there. You have to click to go to a doctor today. So we call it bricks to clicks. That's what has happened. And don't be surprised that if the doctor's office or something would be robotic or automated, that's what, it's not that it's going to happen. It started happening. Change is inevitable. And we are right in the middle of the change. What is it doing? What is this change doing? It has increased the number of patients, the volume, enormous volume it can serve. Patient care, patient experience. We are able to do so much more. And we are able to do it at rapid jet speed. So let's look at the speed. If you take, the change is constant, a change is happening. Here, let me talk about the speed. It took for the telephone industry 75 years to get 50 million connections. For internet, it took 4 years. Facebook, it took 3.5. But Pokemon was 35 days. 50 million users and 35 days. Fantastic, isn't it? The speed at which we are serving our customers. That's what is going to happen, is happening today. And what aspects it's going to? Technology is not going to be isolated. Technology is going to impact humans. That is the human aspect as a patient, as a doctor. Organizations and the processes, the way we structure our methodology step by step, what is the next step? And the technology itself. I put one aspect of the human here, human beings here. If you see the workforce, which comprises of 70, what the statistics say and the researchers say, 60 to 70% of the workforce is going to be a very young, the VUCA world, the millennial world of users. And in the millennial world, if you are not on their phone or a tab, we don't exist. And that's what is going to be the interface. And the interface is going to change its shape and form. So this is on. Shall I the next one? Here, let us take a specific case of a hospital. Let's think there are patients. There is one hospital with 100 beds, 3 operation theaters, and about 4 ICUs, 5 specializations, 25 doctors. Each doctor sees about 25 to 50 patients. 50 prescriptions are written, 50 diagnostics are done, ultrasound, radiology, X-rays, and MRI, and whatnot. So which patient has to go to which room, at what time, what medicine has to be given, which OT room is free, which bed is free, all these calculations, everything, if we had to do a planning, in our good old days, it was in 1990, for such a planning model in a real time, it would take some years, if not 10 years, some years. Regular conventional computers and computing power could do it in probably hours on days. But today, the speed at which we are processing because of the computing power and the algorithms what we have, that's giving us real-time sense of what can be done. So if something is happening fast, it's not just it's happening for just like that. It's happening because of the evolution of processing power, processing is zettabytes, petabytes of data at a fraction of a second. This has changed the whole scenario, the landscape of every industry. Let's go to the next slide. So with this in background, we will see that healthcare and IT has become an integral part of healthcare to be able to serve more patients, give them the patient experience at a cost of a fraction of the cost what it used to be. In mobile health, wearables, telehealth, remote patient monitoring, personalized, and all aspects of testing, of vaccinations, every aspect. So with this, what I would like to do is I would like to pass on to my co David and Shailendra, who will share very specific things, what are having high impact, good patient experience, and better outcomes in healthcare, the areas. Over to David and Shailendra.
Hey, thanks, Raj, for this beautiful transition. We wanted to share a couple of slides about where the sector is going. And so seeing those 8 segments really helps us because we found this very beautiful graph from McKinsey that illustrates, it's kind of complex, but if you notice on the left, you see that more or less this is the output of the market. So basically it's how much money is being, how much money is worth the market at the moment. And you see that it's expected to grow dramatically over the next year. So some estimates give like a multiplier of 4 for the market, which is awesome. It's impressive. It means that a lot of effort is being put into making a full transition on this activity. And if you break it down into the different segments that Raj depicted, like care, telemedicine, operations, R&D, you can see that all of them are going to show a very impressive growth. I think the smaller is like 8%, which is pretty awesome. And some of them are going to be outstanding. These are particularly the ones you can see at the bottom of the graph, the dark blues and the dark grays. So these activities are going to be at 14, 18, 15% growth year on year. And those activities basically are what we see all coming, which is care, telemedicine, supply of new therapies, supply of medicines, and what they call finance and operations, which is kind of complex, but that word means whatever is needed to run a hospital or a health institution, right? So Chandra, maybe we can move on to the next one. Why are those two sectors, care and operations, going to grow that much? It's basically because what's going to trigger it is the cost reduction. Those are activities where being able to do things efficiently is going to change the game. And you will see that most of the things we are seeing landing at the moment are related to that. Shailendra, maybe you can move on. Raj, maybe you wanted to have a word on this description of the COVID
David,
situation.
sorry, I was on mute. So with this projection of how the growth is going to look like in the next years or so, and what are the key drivers which are going to impact the trend in the digital health sector, I think it will be interesting to hear from Raj once again how the health tech is changing in the current COVID times. Raj, you want to talk about this slide as well? Raj, you're on mute.
Yeah, thank you, Shailendra.
Raj, you have to unmute yourself.
There's like a network problem, maybe it comes and goes.
Yeah, I cannot hear Raj at all. Dr. Deepti, can you hear Raj?
No, I can't. Can someone else cover for him, please?
Yeah, sure. So let me. I'll do that. I'll do that. So once again, let me just take a step back, just to make sure that we have the flow. So David covered. David was talking about which all areas are going to grow in the next period, and what are the key drivers. Now, with this slide, we just wanted to show how the health tech is changing.
Thank you, Shailendra.
I think there is a delay
here. Thank you, Shailendra, for chipping in. Can you hear me?
Yeah, now we can, yes.
Okay, thanks. I think some technology issues. We are back. This is something I had to pitch in. Thanks, Shailendra, for holding the fort. What we have seen is COVID has accelerated the whole technology revolution and healthcare itself. Not only in healthcare, every industry is behaving in a different way. It's become more customer centric. It's become more clicks rather than bricks kind of an industry. And let's coming back to our health tech. What we have seen is the moment COVID hit and there were crises all over the world, it was not developed or underdeveloped or developing country. Even countries like UK, France, US, every country which had the best healthcare systems also almost came on the brink of collapsing. We were not in a position to handle the volume and the crisis. So the availability was one of the biggest things. Availability of the doctor, availability of the beds, availability of medicine, availability of care protocols. Right from every aspect of healthcare, the whole world was challenged. But I think the healthcare community and the technology community all came together, and we were able to come up with solutions. And the innovation has been, after Second World War, the analysts and the researchers say this is the fastest and the most accelerated period of innovation and the human evolution. This particular 1.5 year, the number of IPs and research and what has developed has been unprecedented. After that, some of the challenges which I want to bring to your notice, which sets the context of our today's webinar. We have billions of people who had to be vaccinated. Billions of people to be vaccinated in such a short term. And how do we do it? without coming into social contact. So that was a big challenge, and that's where Shailendra and David will chip in how we can do the vaccine. We had to vaccinate 1 billion people without getting them infected. The healthcare workers had to vaccinate 1 billion people without they themselves getting infected. That was the biggest thing. How do we do that? And they have a solution. But very interesting to and discovery and adaptation. It was the first and foremost channel the medical fraternity was faced with. How do we know this is COVID? What are the tests which are available? It is RT-PCR or antigen test or antibody test, and which are the different ones? How fast can I get the result? It used to take about 48 hours, 24 hours. Now we have rapid tests and other things. So the testing of this particular COVID, that has evolved. The for that. If COVID would have taken all the clinical trials and everything about 5 to 10 years to develop the same thing. So you can appreciate, we should appreciate the scientific fraternity, what they have done, right? And coming there, some of the panelists, I have a few panelists here, Amit and Atul. They have worked for social organizations, and also Rajesh from the patient helping community, what we will see. There was a big, how do people find out where are beds available, where is ventilator available, where is remdesivir available? In spite of being a technology world, the whole world, it's not only India or Australia, the whole world was struggling to get one version of truth, one version of which beds are available, where blood is available, where plasma is available. We were struggling. So the information asymmetry, and Atul, who is one of the panelists here, he has got some perspectives. We would like to hear from him. And what we saw is one of the doctors in one of very famous hospital, one of the leading hospitals in India, she quoted that if we want to reduce the trauma and death, accident deaths on the road, you don't build multi-specialty hospitals. You correct them, you avoid them at the highway. No, you don't make accidents and then build hospitals. That's not going to solve the problem. And likewise, there are some solutions which our scientific community and WHO, everyone said that. For COVID, it's not the number of ICUs you build. There was a low cost or a no cost impact solutions just by doing masking and social distance, we could have avoided that. And some of the countries have done a fantastic job. South Korea, for example, did tracking and tracing like nobody in the world. Phenomenally, they were able to track. They were one of the earliest countries which were able to track and trace and put the surveillance in place and able to isolate the people timely. They were able to solve that. That algorithm was also used, that kind of algorithm was also used in India, and a phenomenal, very great application. It's called Arogya Setu, and it is free, and it's from the government of India. And it's so nice to see that even government developed certain nice things. And when if somebody who doesn't know Arogya Setu, it's an app where you register yourself, and the moment you're on, you switch on your GPS, you switch on your Wi-Fi, it would tell you how many people with COVID positive are there in half kilometer, 2 kilometers, 3 kilometers. If you are going for shopping to the supermarket, to Walmart or anything Asda, if you see that, you can avoid, go to the other place. And that was something very cool, I thought. And Arogya Setu was able to, is not only doing tracking and tracing and isolation, but it's also able to real-time basis say how many people have got vaccinated with the first dose, how many people with the second dose, and getting real-time information for surveillance was fantastic. That was something new. Then what we were seeing is every country, every institution, whether it's Australia, it's New Zealand, UK, NHS, or US, everyone was having different, everyone was trying inventions and discoveries for protocols of treatment. But once they found that this is the way to go, how do they disseminate, how do they proliferate this particular knowledge to everyone, every institute? And this is where, the power of technology was the protocols, the algorithms which they released, the APIs what they gave, that helped us in standardization of care and following the protocols. We have, if I use some of them, I'll share some of the practices there. So that's about it, to just give you an overview of some of the things what we have observed in COVID. There could be much more, but this is something which we have touched and felt and seen the impact of technology in COVID and overcoming some serious problems with some simple solutions, and solutions which were able to be, adopted by a common citizen, a person on the street. Thank you, Shailendra. Again, back to you.
Thank you, Raj. That was a very beautiful summary of how things are changing in the light of COVID. With that, we have got a slide here which we want to talk through, which talks about some of the new tools, apps, technologies which we want to cover, which we want to talk about. Thankfully, Raj, you've already talked about Arogya Setu. We are all fully aware of QCrash and Helfa. We will talk later in the session. David, can you just briefly go through EasyGain and Dr. Louis and Anomalies?
Yeah, sure. We selected those because most of them were already players in the software for healthcare, but they've all pivoted very quickly when the need to cover a major need of vaccination came, or tracking. So we love these three examples. Doctolib is a big catalog that allows people to plan their visits to the doctors. So it's basically a calendar for doctors. It's an assistant. And it's a unicorn here in Europe. It's a very large firm which is expanding rapidly. And they immediately put the platform at the use of the National Health Service in France to be able to program all those jab appointments. So it became the central platform. So a tool that was used by individuals to go to their doctors became the central element, which was kind of the hub, and it was fundamental. So wonderful effort, and very simple, super simple technical solution. There is nothing new to it, but again, it has become a fundamental need for every citizen now. We love EasyGain, which is a completely different topic. They use real advanced technologies such as virtual reality and artificial intelligence to offer solutions to rehabilitation, patients' rehabilitation, to have them move away from specialized buildings and institutions and be able to do it on simpler premises. So they have a beautiful product, which is it's going to be fundamental as well. And Anamnes is, we selected it because it's one of those companies that offers a backend to hospitals, but little by little they've moved to coming upstream, if you please. And so they're doing telemedicine in order to unload a bit the hospitals from the traffic they get, and a lot of prevention. So they have bots that have regular conversations with their patients. And before the patients even decide to take the step to go to the hospital, thanks to their answers to the questions, you can detect that some symptoms are being manifested, and so these patients should be handled in a priority. And some others, because of the answers they're providing, you should not worry, and you can have them safely at their home. And so this is, again, one of those solutions that allows for prevention and a lot of efficiency. And these people were very quick when they had to move on COVID. And instead of doing the tracing after one person showed symptoms and did the PCR, they started polling the vulnerable people, the elderly, people with diabetes, and so on and so forth. And before they could even, call the doctor asking for help, they could detect if they were getting fever, and they could get in the radar before they became a COVID confirmed case. So a beautiful solution. And again, this one also has artificial intelligence, so it's a bit sophisticated. It's very beautiful. To you, Sharendra.
Thank you, David. That was beautiful. Just another perspective as part of the current discussion. While there is a lot of push from technology players in the health sector, there has been some influence from the governments as well. Just wanted to take two examples here. As the the technology is trying to bring in new types of solutions, new types of innovations to help healthcare industry. Governments are also stepping up to be part of that and to make the things easier for the technology players in this sector. For example, in Germany, they have passed a new law which actually allows the patients to take the benefits from any digital app if they are taking any treatment from on digital platforms, which were actually not even recognized a few years back. They are all part of their social security system, which means that if they're taking a medical help from on any of the digital platforms, they should be able to claim it back from the social security, which is a fantastic and very, very big step to allow the patients to feel free to choose where they want to go to when they have a problem, whether they want to go to a traditional hospital or they want to choose any of the digital platforms. Likewise, in France, as I understand, they have given a mandate that by 2022 they would want all of their patients or their citizens to have a digital health record. So everything has to be digitized by 2022. So these are the kind of some of the new things which are coming up from a government and regulations point of view, which are also going to drive the way things are happening in health tech sector. With that, we will very smoothly move on to our next part of the webinar, which is the two case studies which we wanted to talk about. Let me just change the slide. Am I audible?
Yes, Chandra.
Yeah, I'm just facing some problem in changing the slide here. Bear with me for a second.
If you like, Shalindra, I can share it from my end.
No, it's all right. It's all right. Just one of those things. I'm on it. Sorry about that. So this is the slide. So we are very smoothly moving on to the two use cases which we want to talk about. The first one is Helfa. We're going to call Raz again. Raz, you will talk about Helfa. Raz, are you there?
Yes.
So I'll just hand it over to you again.
Thank you, Shalindra. So, Shalindra, can we quickly go to the next slide, please? Yeah. I think this particular slide, I like it. But why? What was the issue? If you see the graphs on the top, it's like going up like no one's business, and everyone. It was very scary. You remember the phase one, wave one, and wave two. What was? Why are we talking really about COVID, and why COVID is such a big deal? Because the cases were increasing very steeply, and the whole healthcare system was absolutely in no shape to handle anyone, be it any country. Non-availability of hospitals, non-availability of doctors, nurses, and hospital care was absolutely not affordable. In India, at least, the situation was there were many people, the only hope for them was hope and pray, and wish and pray, nothing else, because it was so expensive. But that's when the whole thing started changing. And thanks to the medical fraternity and WHO and all these people, there was a ray of hope that there was very good recovery rate and mortality rate if we followed some practices. And that's the birth of Hilfa. We saw that 40% of the patient base was asymptomatic, which was a very good candidate for home care or remote care. They did not need any hospitals, any oxygen, any serious therapy, no ICUs and ventilators. And 40% of the mild to moderate on the borderline within the thresholds could also be taken care. And it was only the 20% which needed hospital care, out of which 5% needed ICU care. What was happening was people were just hoarding on the resources. People who did not, just because they had money and they could afford, they were occupying the beds in the ICUs where they didn't. This madness stopped because of the protocols and when the earliest when we suspect we should get into a COVID treatment. So this is setting the context. We'll just move to the next one, the genesis of why COVID home care Hilfa thought of this one and this one. This was the one which gave birth to the Hilfa's COVID home care. Next slide, please. So who are the people, who are the candidates who are eligible? Anyone suspected of COVID, asymptomatic, pre-symptomatic, mild cases, definitely a category 1. There were a no-brainer. And what we have seen is we have had a fantastic success rate. Not only anyone who followed the protocols and did it systematically, they were able to give low-cost, affordable solutions and treat COVID with a very good impact. Which were the areas which were great? Elderly patients more than 60, children less than 10 years, and pregnant. This is the question mark. Wave 1, definitely the medical fraternity say it's a no. You cannot take these cases. They cannot be home care. We don't know when they will turn south and get into a risk. But come wave 2, the whole world learned that these are the people, candidates, which can be treated in home care with a little bit of caution. Children, pediatricians could take a call, and elderly patients, the general medicine, internal medicine consultants could take a call. Pregnant and lactating women, the gynecologists could take a call on this one, which actually feed them, and we were able to treat much more bigger population. Some people which was a no was anyone with comorbidities or any of this immunocompromised patients. It was a no because we don't know when they will turn south, and definitely home care is not meant for them. So this was the base. These were the eligibility criteria clearly set by the medical fraternity and the health management fraternity and the contra policy makers. That made life easy for us, which was the foundation for that. Now, if we have that, is it enough? What we saw, a digital thermometer, a pulse oximeter, and a smartphone. These were the things which we had to have at a patient end. As a patient endpoint, if we have that, the doctors had the ability with the technological advancements what we have, virtually doctors and nurses were able to take care of the patients as well, much better than physical presence in many cases. For some devices, like diabetes patients, they needed to have an additional glucometer. And people with hypertension, any of CADs, they needed to have a BP apparatus. We could take care of them. So these are the additional optional devices. But anyone who is suffering with diabetes, they would mostly have. We have seen that 80%, 90% plus of the diabetic patients, they already had a glucometer. So it was not a bigger ask from a patient point of view. These were available. Let's move to the next slide, Shalindra. So the construct of this one, the foundation of was ICMR, Ministry of Health. The News 2 protocols of Royal College of Physicians and NHS laid a very good foundation for us. They were able to give an algorithm which was giving the COVID risk assessment score. The risk stratification score was giving us an input for deciding 2 to 3 things. Number 1 was where can they be treated? Number 2, what is the frequency of monitoring? Number 3, when it has to be escalated. With clear rules and algorithmized SOPs, it was very easy to put algorithms and build that. So Hilfa was built on these premises, complying to the national and the international norms, and we constructed. So this is the brain behind that, using AI, ML, and all the other algorithms. I will not bore you with the technical jargons, but this is what we were doing. And what it was doing, Hilfa was able to do teleconsultation, video, audio consultations with the doctor every day. Telemonitoring by the nurses, remote patient monitoring every day. A dietitian and physiotherapist was required for their well-being and their eating habits so that they have the right diet to recoup and the physiotherapists for helping them with the chest physio. And some of the patients needed some additional care. They needed some psychological or clinical psychologists at times when their depression and mood swings. But that was not a very big percentage. Those kind of things we are seeing in the second wave. The key stuff though is the initial assessment. That's the key. That's the secret sauce of the COVID whole healthcare. That gives us where the patient is and everything. I will allow the doctors and the consumers of HEALFA, the people who have used HEALFA as doctors and medical practitioners, and the patients to tell me about that one. So for the 24 hours helpline, we were able to render the home care. But was it only home care? No, it was home care, it was isolation centers, COVID centers, quarantine centers. In India, they converted a lot of stadiums and schools into COVID centers and isolation centers. You can build buildings and put beds and everything, but where do you get trained staff? There was an acute shortage of doctors and nurses. That's where HILFA came in with the algorithms. Even students, interns were allowed and permitted by government of India. Nurses and interns were allowed to do that. They were able to, rookies were able to do the job because of the algorithms and the monitoring of things. There is another scenario which we faced in COVID. Not everyone in Indian context knew how to use a mobile phone. They were elderly patients, illiterate. They didn't know how to use mobile phone. And some of the people were so poor, they did not even have a device. So in those cases, that's where our innovation of virtual clinics kicked in. And we were able to set up this virtual clinics by sending this one device. This one device does about 8-9 things, ECG and all those things. And a semi-skilled person in one day can be trained, and that person was able to connect to the doctors. That was the point of presence. So in this case, where patients did not have the instruments, or the patients don't know have a mobile phone or don't know how to use a mobile phone, the school in that particular village or town, or the library, or the police station became the point of presence. And people would come there to the closest proximity and do that. So this virtual and teleconsultations with a clinic without a doctor was a very successful model. We have been able to see that. We put it in schools, we put it in libraries, we put it in public places and community halls, town halls, and we were able to do that. Different scenario. Shailendra, let's move. Yeah, to the doctors, this would be of interest. This is the NHS News 2 protocol, which is one of the basic recipe for how do we do the scoring, how do we do the protocol based kind of thing. So this is what we have. It's a scientifically based algorithm. Next, please. And here, when we have rookies and just student nurses, student medical students who were doing that, who were not yet done, where the intelligent monitoring, the AIML, the algorithms were able to guide them as the temperature, pulse oximetry readings, everything was coming. Hey, this is red, this is amber, this is green. You need to do this. You need to escalate now. So these dashboards and monitorings at an individual and a parameter level they were able to do not few tens or dozens, hundreds of patients across quarantine centers and thousands of patients across institutions were being done. So very proud and very happy that with the help of technology we were able to solve that. And for doctors, yes, we have an app which was just click on a button, and most of the doctors have a mobile phone. And if somebody can use a WhatsApp or somebody can use a chat, they should be able to use that. It took hardly a day or two for the doctors to get oriented. Yes, the first one was not easy. First 1 hour, 2 hour, first day was a challenge. But after that, they felt comfortable and they were able to manage their patients very well. On the patient side, next one, please. On the patient side, this was an assurance. It was like, they are able to see what are the level, they are able to see the prescriptions, they're able to see what the doctor is saying. And in real time, if phone a friend available 24/7, who would answer at the other side and guide them and counsel them was a big deal. More than the medicine, the availability and the assurance and they are able to see their progress or their deterioration was a big deal for the patient. They were seeing which way they were going, the north, south, and what was happening to their health. Next one, please. So, Shailendra, can you click the small video on the right-hand side? It's a small video to just illustrate what we are doing.
People across the globe are grappling with the fear of COVID-19 pandemic. With the shortage of healthcare facilities and professionals, there is an urgent need of a platform to cure patients remotely that are asymptomatic, or patients with mild and moderate symptoms. This is where HealFast's home care app for doctors helps them to connect with patients and treat them remotely. A doctor is provided with all the data from HealFast app that has patients' vitals, that is temperature, pulse rate and oxygen saturation, blood pressure and blood glucose reading. A doctor then treats the patient remotely with the help of a nurse, physiotherapist and a dietitian assisting the patient with necessary care at home. HealFast offers many features to benefit patients with the ease of consultation for doctors. Download HealFast app for doctors from Play Store, register yourself and start treating the patients remotely through the path of COVID recovery. With an end-to-end health life cycle monitoring, HealFast is the right choice for doctors when it comes to remote home care during COVID times or otherwise. HealFast Home Care is available on web and as a mobile app.
Thank you, Shailendra. Can we go back to your
Raj,
slide?
yeah, just wanted to say I'm a bit wary of time here. Some of our panelists might have some other engagements.
Sure.
So I just wanted to quickly wrap it up. And also I wanted to skip the Q crash section and wanted to reach out to the panelists for them, if we have some inputs, we want to talk to some of them. So I think we are closing this, right?
Thank you. Thank you. We're closing it. So over to you. But I think Q crash was a phenomenal thing, what I have seen. You should cover that.
Yeah, just give me 1 second. I want to stop sharing. Sorry, I have the same problem again. Amit, you said that you have another appointment.
I think.
Yeah, can you hear me?
Yeah, now I can hear you.
Hello. Yeah, I apologize. Something just came up at the top of the hour for me in a few minutes, but yeah, happy to participate now.
Yeah, so Amit, I just wanted to kind of change the course of the talk here and ask you a simple question here. You've been in the center of most of the work which is happening here. With your experience, whether it is health or Q crash or any other thing in the India COVID support, I've been running so many things. What is your take on the use of technology in general, not necessarily about any of the products we're talking about, how it has helped you, do some of the work which you've been doing? Just a simple question, whether it is data gathering, talking to people, informations, everything.
So yeah, technology definitely has been integral to everything that we have done over the last 4 to 5 months since we started India COVID support. And the more I have thought about it, I believe we could handle smaller scale interventions without plugging in technology. But the more we need to scale and drive predictability in the way we operate, that's where technology definitely plays a key role. And so I think the scale aspect definitely, as we start moving from neighborhoods to cities to states to countries, right? The technology platforms play a key role in solving for scale. So that's my take on technology. And of course, there is that whole piece around analytics and insights and process automation, where technology again can play a key role. And something that requires us to operate at the intersection of the medical community, the IT folks, the government agencies, and the not-for-profits all need to come together and define projects with clear outcomes and leverage technology to drive those outcomes. Yeah. Over to you, Shailendra.
Sorry, guys, I was on mute. So thanks, Amit. I just we have 2 more minutes. I just wanted to jump ahead a bit. You've also been using both
Shailendra, there is no shortage of time. Please take as much time as you need. So we do want you to go through the whole presentation.
No, we will. I just wanted to make most use of Amit's time, because as I understand, Amit might have to leave in a few minutes' time. And since you've been in the center of some of what you've been doing, I just wanted to capture his feedback, his impressions on the 2 products. And then we will revert back to original course, Dr. Dipti.
Sorry about that interruption, Dr. Dipti, but I just figured that there was something happening in one of my markets that I needed to get to. But yeah, no, both the products, right? So we are lucky to have both Hilfa and QCrash as partners, right? The QCrash solution solves for a very fundamental need that we need in the healthcare space. And in April, when we were seeing the whole the risk of getting vaccinated and visiting crowded centers in India was the biggest risk of getting infected. So QCrash did play a big role in solving for that problem. We definitely need to scale up and drive greater adoption for the platform. Hilfa, I have personally used it for a close family member, the platform, and have seen it being used, right? So that offers great value because it operates at the intersection of technology and medicine, right? So it gives you the technology platform, it gives you the medical expertise, right? And anything that operates at the intersection of those 2 areas has created a lot of value. It has kept people at home, kept them away from hospitals, which were already overburdened. So again, it's very, very good feedback on both the products. Yeah.
Thank you, Amit.
Thank you.
So with that, we'll go back to our flow. I'm just going to start sharing my screen once again. So we heard from Raj about Hilfa, how Hilfa has been helping to all those patients who have not been able to reach out to doctors in person for different reasons, especially in the COVID times, and how they've been able to seek medical help and attention through this fantastic product. That was I'm just going to go to so that was about Hilfa. Now we'll move on to the next one, which is QCrash. QCrash is a product where we are going to digitize, or we digitize the queues at any healthcare center and inform the patients in the queue that when exactly they should come, and that allows us to give or to generate a lot of benefits both for the healthcare centers and for the patients. So let's have a look at this slide. If we look at COVID vaccinations drive in India, what is the current situation? We've got 180 million people vaccinated, which is just about 13% of the total population. There is a whole, if you look at any report, photograph, you are watching it on television, you see long queues. Although the situation is changing, but it's not much different. Long queues, people are queuing up for a long time to get vaccinated. There's a bit of chaos there. There's hardly, in terms of adhering to the COVID protocols, you could clearly see that there's a whole bunch of risk there. people are not necessarily following social distancing. Not all of them are wearing masks. And that process itself is creating a challenge of COVID spread, that people who are actually going to get vaccinated might actually get infected instead of vaccinated. And for some of the areas where, and I know it from my personal experience, so a lot of people were very much, they didn't want to go for vaccination just because of the reason that, they thought that these places are so crowded that they will actually get infected. Also because of the fact that all these people are kind of waiting in the queue and for hours, many of these poor people, they actually are losing out on an opportunity to earn their livelihood. They're just not able to earn money, which is also a big factor. So the key challenge here then remains with us, that how do we vaccinate billions of people effectively without having risk of massive COVID spread. And that was the challenge which we took as QCrash founders, David and I, and we had this product which is called QCrash, which is an app which eliminates the waiting time in the queues, and by that it simply reduces the crowd at any service point. Although it was initially designed for healthcare, but it could be used for any location which is offering a service and people are queuing up at that location. So whether it is a government office or a tourist attraction or a retail shop. So at this point, I'm going to play a video here, which we produced for India COVID situation, and just to try to illustrate how our product is going to help in the current pandemic situation for the vaccination drive. Let me play that. Sorry, I will just restart it. So that was the video, which hopefully gave you an overview of the product and how it works. Once again, the focus here is to digitize the queuing process for any healthcare center wherein people are coming and they are waiting for a service. Just important to note here is that it is not only working for a queue where it is like a walk-in queue where people are just coming in or dropping in and they want to be served. It also works for a queue where people have already fixed appointments, as in you have an appointment at 11 o'clock, 11:30. We all know that these appointments eventually tend to get delayed, and in 11 o'clock appointment typically happens or takes place at 11:30 or 11:20 or something like that. Even in those cases, this app is able to capture those delays and inform the patients that they should be coming at that particular time. Another thing which I want to highlight here is that even though it is an app, it works for people who do not have these apps or who do not have a smartphone or even they do not have a phone at all. So basically, the app has been designed in a way that it is very inclusive. It can include people who have a smartphone or who do not have a smartphone. If you do not have a smartphone, you will start getting SMS as an update for your appointment. So it does take care of everybody, each kind of population. How does it work for patient? It's very simple, as you said, as you've already seen in the video. You search for a healthcare center, you join the queue, you see all your appointments at one place, and then you keeps on getting notifications for each one of your appointments, and then you go when your appointment is due. You can also inform if there is any delay as a patient. If you're delayed for 5 or 10 minutes, you can inform the healthcare center that I'm delayed, and the healthcare center is then aware of your availability. Likewise, how does it work for healthcare centers? It's very simple. You set yourself up. Once you set yourself up, you are visible to your patients. They can join it. You can see your traffic, how much traffic you have on a particular day. Accordingly, you can staff it, with more people. If you've got more traffic, if you've got less people, you can allocate your staff somewhere else. You keep on getting notifications when somebody is canceling any appointment. Then you're aware of it instantly instead of just finding it out in a normal scenario that, oh, this person is not coming at all. And then you serve the customers who are in the queue, and in this process, you become social distancing compliant. I just wanted to highlight here another aspect of our product. It's not a regular appointment system. That's something which is probably our USP, that we're not an appointment system. We continuously track the progress of the service in a particular queue, and thereby we inform the remaining patients in the queue that when are they going to be served. So it's not that you just get an appointment at a time and then that's the time when we have to go. And when you go there, then you just find out that actually it's not going to happen on that day. It's delayed for half an hour or so. So we keep a regular track of what is happening in the queue and then inform the patients accordingly. This is probably our last slide. We have got 3 principles for our product. We want to eliminate the waiting times for our patients so that they don't have to sit and wait. They can do whatever they want to do in that period. And that would also mean that for the healthcare center, you'll have a full view of how is the load on a particular queue, and so that you can staff it accordingly as it varies from from one day to another. Also, you will see how you've been performing on that particular queue in the course of a day, and then you can decrease the idle times in your queue, and that would improve your operational efficiency, and that would mean that it will have overall gain in the productivity. And finally, which is probably the most important point in the current times, is that by doing all this, we just keep the locations very safe, because there is no crowd formation at that location, and that means that people are COVID safe there. So that's what about our product. And then just to talk about where all we have implemented it. We have implemented it at a couple of locations in India, which is Bloom Hospital in Hyderabad. We have worked with the Urban Foundation, which is an NGO, and another one in India COVID Support, which Amit represents. We have worked with both of these NGOs, and we have done a number of pilot implementations for their COVID vaccinations drive. We are at the moment talking to the NHS, not only at University Hospital Coventry, but for some other locations as well, where we want to implement as a pilot project in the NHS UK. So that was all about queue crash. I'm going to take a bit of a pause here and wait for some questions in general, and then probably I think there are a lot of questions on the Q&A session. I'm going to have a look at that, and probably we'll start with the question and answers.
Yes, that was Shalendra. So if anyone has any questions, now is a good time to pop them in the Q&A. Again, you can choose to submit your questions anonymously. And Shailendra, feel free to start addressing those questions, and you can direct it to whoever is part of the speaking team, whoever you see fit.
Yeah, absolutely. I'm going to do that, although I need a bit of a second to understand the technology here. Has somebody started a poll question?
Yes, I'll get one of our kind volunteers to also initiate a poll. So if all of the attendees can submit an answer to that, that would be great. But yeah, Shailendra, off to you.
Thank you, Angeline. Let me just quickly have a look. I'm going to ask the first question. How do you manage data privacy in these applications? I'm going to ask this question first to Raj. Raj, in your app, this is a question coming from Girish. This is a question. Raj, are you around? Raj, can you hear us? All right, let's take it for QCrash. David, how do you manage data privacy in QCrash?
Sure. So you know that as we're a European company at its foundation, we are under very severe data protection laws with the GDPR. And so luckily, our service is very basic. So we only hold a mobile phone number and an appointment time. That's basically all the information. So there's no data as such that we store. And these very basic data is sent to the vendor. And with each vendor, or each hospital or a health institution, we sign an agreement where we are both recognized as joint controllers. So we both take our responsibilities in terms of protecting that information. And of course, we offer the patients the typical rights to review, delete, cancel, and so on, every information we have. But particularly, we don't store any health-related information in our systems. That is, it is very critical that we just stay as the queue management system. So they hold their own information and they share it with the person they have to share it with, which is the doctor or the hospital, not with us.
Okay, thank you, David. Raj, are you available? I cannot see. Are you on mute? All right, I'll move on to the next question. In the meantime, there's a question, very interesting question from Naresh Khanna, as he's talking about bots. I think his question is pretty fundamental and an interesting one. Are bots going to take over doctors and the medical processes in the future? I think I will pass this question on to Dr. Deepti.
Maybe Dr. Vijay might want to answer that.
Yeah, actually.
Part of the panel. I hope it doesn't. I hope it complements what we do rather than take over. But I'll get Dr. Vijay to answer that.
Yeah, my take on bots or an automated system to take care of patients is very simple. An automated system works well when the SOP is in place. And then the exceptions are also very clear. So an automated system is great for a place where you know what are the exceptions and what are the things to be done. The moment the exceptions arrive, the doctor's role starts. And we have seen in our practice that 80% of the work is routine and very repetitive, which actually would not require a consultant's time. Because the rules ask for a doctor to be present, it is junior doctors who take over that job. I think when we're managing bigger numbers and we have to be more cost effective to be able to reach to a larger population, it would make great sense to segregate those things. And yes, their bots will be very important. They will not replace the doctors, but they will definitely complement them. Thank you.
Thank you, Dr. Vijay. Excellent, excellent. That was good to hear. I'll move on to the next question. There are a lot of questions here. I'm just struggling to manage which one I should choose. All of them are so interesting. There's a question on queue crash. I'll pass it on to you, David. The question says that if the person needs to scan the queue crash QR code, he will already be at the location. So how is it going to help the crowding situation?
Yeah, well, not forcibly. Maybe, maybe the institution has shared that QR code through email. Maybe is it on the website? Maybe can you get it through WhatsApp by a friend? So you don't have to be at the premises. Maybe the first time you get to learn queue crash is because you see the QR code somewhere in a waiting room. And then yes, but that would be the first time. Then you already know the application, and the next time you'll do it from your home. So you don't have to be there forcibly. Yeah.
Yeah, thanks, David. I think that is the key. Just to add on that, the first time you might, if you're not totally not aware of the app and the fact that app is being used at a particular healthcare center, you will go there and you will kind of you will have to scan the QR code. But from that point onwards, you don't have to scan. You will have it the app. You can join the queue from your home, from your office, wherever you are. So that was the answer. I'll take a question from Girish now. And that's an interesting one again. I think, how are we going to ensure, I'm just paraphrasing it, that the algorithms which we are using in our apps, I think it's more relevant for Helfa, is relevant to the new emerging data. So I think Raj is still not around. I cannot hear him. We could talk about our queue crash, David. How we are kind of trying to be on the top of things as things are moving. Even when we started our pilot projects, we have been learning a lot and we're changing our algorithms. For example, this the fact that we include people who do not have smartphones and all those other changes which we are doing. So basically, it's for me and David. I'll let you speak in a second. I just wanted to take that one. It's a very continuous process, like any other software, whether it is algorithm, whether it is a logic, or whether it is even the interfaces. You have to keep on changing as the things are changing, regulations are changing, the patient's experience are changing, the patient expectations are changing, and many times the process is changing, itself. So it's just like any other software. You have to keep on updating your logic, which is i.e. the algorithm and the data and the way it operates. So it's an ongoing journey, isn't it, David?
Absolutely. Maybe also the question talks about artificial intelligence, in which case, there's one pace for software, which is rapid. We can quickly respond, but artificial intelligence, you need to train algorithm. And so in order to do that, you need large volumes, collection. So maybe the time is longer for those other activities. So the example Vijay was giving before about bots and stuff, who are like having a intelligent behavior, those need some more time to adapt. But again, it's just a matter of defining the goal, and in the end, in a few weeks, you get the results.
Thanks, David. I'll go to the next one now.
If I can chime in, Shailendra,
yeah,
can I chime in?
Please, Vijay. I was just hoping to do. Yeah.
Regarding how do we adapt to the changing scenario when things change? What we have seen with the News 2 application in monitoring a patient is very basic, very fundamental. It tells you whether a patient is unwell, getting better, or fine. So that is standard across diseases, across hospitalizations. That kind of remains with. To particular diseases, you add particular things, particular extra segments. And regarding the treatment protocols and all, yes, they have to be changed. And nothing has been more pertinent in COVID than change. In COVID, we have seen the change happen daily, weekly, hourly. And yes, we have to change, and there has to be a team which is onto it. And that is what will probably keep those healthcare apps ahead of the others.
Absolutely. Very well said, Dr. Vijay. Thank you. I think there's another one which is equally interesting here. And I think I'll direct that question to you and then to Atul as well. Atul is also available. What would you say is the biggest hurdle to the technology or technological advancement in the current times, if there are any? That's a question from Shashank Paliwal, if I read it directly. So what is it in your views, Dr. Vijay?
The biggest hurdle that I see is able to build trust across a virtual platform. So that would remain the biggest hurdle, because you don't know your doctor. Can you trust him? So that will be the biggest hurdle, and that is where branding probably will step in. You will trust a brand. So from individuals, it will change to brands, and you will depend on the brand to give you the quality check. That is what will happen from the patient's point of view. And from the doctor's point of view, can I trust my patient to give me real data, or is he fudging it just to feel safer? Is he just trying to give you what you want to hear? I have seen this happen in COVID home care. People gave the number that we wanted to hear when it came to saturations, blood pressures, because they were afraid we will ask them to visit a physical facility for a further check. It does happen. So that's where the challenge is from both sides. Branding and quality control can change it from this side, but how do we change it at the patient's end? I'm not very sure, unless we are able to convince them that it's going to do them harm. Thank you.
Yeah, I think that was something which we all have experienced when we are talking to the doctors, especially on the phone or remotely. You tell them what they want to hear, or you tell them what you want them to hear. Sometimes it could be far away from the reality. Actually, I just would like to share a quick personal experience. One of my close friends, in fact, and he had COVID, and he kept on avoiding it for 15 days, and eventually he couldn't survive. So to your point, Dr. Vijay, the trust is quite in the center of all that. Atul, we have not engaged with you. I would like to hear your opinion. When we are talking about all this technological advancement, from your point of view, what do you think are the key challenges?
So I would say that, of course, completely agree with what Dr. Vijay said in terms of the trust factor. To my mind, there are two other elements that come, close. One is the whole awareness piece. There's actually, when we go in, especially for COVID, we go through these waves and phases. There's just too much noise, and that voice of sanity or the voice of reason, or even the basic awareness about some of these platforms, I think could be critical. And I mean not just awareness at the level of people who are potential patients or caretakers, but even at the GP level or the doctor level, where they could possibly guide these patients or their caretakers to such platforms. The second is, I think there is a need for communication that builds the required amount of trust and confidence. And to me, these two elements, they might be, they might be critical to kind of aid in this whole acceptance or of the technology platforms that exist today, that leapfrogging really happening. That's what I would say are the critical call outs for me.
Thank you, Atul. Very interesting. I'll move to the next question. That is again back to you, Vijay or Raj. How do you ensure that the care which was delivered is as per the standards and was safe?
Whenever we have done it on a larger scale, like we did for the Hyderabad Police Department for an entire zone. So what we did was, there was definitely a mentor monitoring the doctors. Similarly, we had our ears open from the technology side to help out the patients from their inability to access something or things going wrong. Then we had, from the patient's point of view, Rajesh was taking care of them from their organization. So these were the things which made sure that we were delivering. Otherwise, if we didn't have those regular meetings where we were checking out whether we are falling short, I don't think we can deliver quality care. There has to be an analysis all throughout. Rajesh, I think, will be able to give us some info about how he helped his entire community of police personnel in handling and getting the right care, and how he could change it, fine-tune it to their needs.
Thank you, Dr. Vijay. Shailendra, do I have your permission to?
Please, please, apologies. They've not been engaged with you earlier. Please, please.
Thank you, thank you. We had around 950 officers who went through around 45 to 50 days of intense monitoring during COVID and post-COVID as well. There were a lot of learnings, but I think 3 or 4 things that I would want to bring on to this discussion, which probably has not come in. One is that there are a lot of tools in the market which might be apps in healthcare. However, there's a huge differentiator that the promoters of these tools bring, which I would definitely want to bring onto the table, because we had a very different wave 1 and wave 2 experience. Wave 1, the disease was a mystery, the cure was a mystery. Wave 2 was very different because of the variants that had come in. The RT-PCR was mostly negative, but all symptoms of COVID were there. We realized that when confronted with the reality of death, different people act differently. So all these challenges we were facing, wherein we had to quickly implement a uniform, standardized response protocol. And that is where, of course, the HEALFA app definitely helped. But what helped was the presence of passionate promoters who actually spent a lot of time with us to ensure that this functionality works and this entire setup works. From our side, we had put in 16 officers for monitoring. But HEALFA, Dr. Vijay Shekhar and Raj Shekhar, they had not only provided the app, they had also provided managed services. So there was a large contingent of doctor volunteers, nurses, and other volunteers who were working on their side, and 16 officers on our side, to ensure that no ailing officer had the choice to decide what to do next. We had to take away that choice because we were confronted with the reality of a lot of people dying because they were not taking action in time. Just like what Shailendra said, that a friend of yours might be sneezing, would have light fever, and then there'll be some breathlessness, and on the 15th day he died. A lot of people in our case were dying, we're not waiting till 15th day to die. So we had a huge challenge wherein we brought in this entire HEALFA apparatus, and with them we got illustrious and eminent doctors and our own officers, and we put in a set of protocols. So if your SPO2 monitoring alert came in on the app as it is less than 90, then it was very clear that the ailing officer's supervisor is responsible to take him to our isolation center within X hours. We stopped interacting with the ailing officer after the first 2 calls saying, please move to the isolation center, your ambulance is outside. If they don't move, the superior, the senior officer gets a call right from our heads of businesses, heads of police. And so it was a very close-knit team which enabled this. So I think what I want to bring to the table is that the apps themselves may not be a game changer. A lot of times what the apps bring with them in value from the real world also makes a lot of difference. So that's one thing I think is an answer I can take. Over to you, Shyam.
Thank you, Rajesh sir. Now that you're here, I'll take another question for you. What do you see is the, and of course it's more or less we've talked about it, but just to sum it up, future of IT in managing any further pandemic situation or the kind of situation which we have faced in the last couple of years. Where do you see
I think it's a
IT sits?
very interesting question. See, any industry which crunches big data. For example, in policing, our surveillance camera systems is humongous big data. When we come into with AI, facial recognition and all, traditionally, policing systems across the world in the last 1 decade or so have been crunching big data and has been helping in machine learning, deep learning, and also a lot of AI analytics is coming in. A simple, let's say an investigation into the whereabouts of a criminal, if we were to trace his last 3 months history of cell phone records, it will be millions of rows. So any sector which has availability of big data, whether it is healthcare, whether it is policing, whether it is any other sector, there would naturally evolve a set of thumb rules based on artificial intelligence, which would guide the way forward. So this isn't an exception, this is a rule. That is one side of it, that the technology will always be the key differentiator. It will lead from the front and cause disruptions. So that is for taken. I am not going to debate on it at all. The big challenges that are going to come is how effectively we can manage the transformation on the ground. For example, the biggest challenges that we see in India is adoption of technology. The moment you ask somebody to download something, they would say it's not possible. We would not download. Our storages are full. We don't trust this app. Why should I download? They would only download Arogya Setu, which is probably one of the highest downloaded health apps in the world, in the history of the universe, I should presume. The reason why we had to download it was there was a scare factor that if you have Arogya Setu, then you would know if your neighbor has COVID or not. That was the day one story. Okay, that's one. The second was you cannot enter any public space. It became mandatory. You have to show it. Every questionnaire and every activity had one question. Have you downloaded our Arogya Setu app? Yes. No, we are talking about a country which doesn't have digitized patient records as a statutory policy. We are talking about a country where our Aadhaar linkage, for example, they have the social, I think it's in America and all, it's called the social number.
Social security.
Social security number, yeah. So in India, it's called Aadhaar number. It is not linked to any prescription. It is not linked to a doctor's visit. Only now things are changing, in which linking of multiple databases are happening. In this scenario, adoption of technology, unless it is forced by policy, or there is a genuine need beyond the immediate, or that is the only option. Otherwise, these will not come. It's very difficult. Most of these players in technology would have very small segments where technology is downloaded. That's one part. The other is the big difference between downloadable versus web versions of apps. Increasingly, the largest web providers are understanding that smart clients don't work. People won't download because there's already so much of distrust of what the app is doing. Why are they asking permission? Why do they want to record my audio, my video, my screen, my contacts? Already a lot of, and in fact, you would have seen large apps like Truecaller and WhatsApp and all coming out with full page ads in India saying you can trust us in indirect ways. So downloadable apps versus web-based apps, that is also a game changer that will decide whether these technologies will get really adopted. And of course, the value differentiator in terms of not just an app, what more? Is there a phase behind? And that's where the HealFA definitely scores, because you can call somebody real time and there's somebody to take up on, take your call on the other side. These are things that makes a lot of difference. So that was my 2 bit.
Thank you, Rajesh. It was very, very interesting to hear your thoughts. Since it's a broad one, I'll just leave the floor open for a few seconds for any other panelist members to chip in and say something on this topic. Atul, Vijay, Rama.
Shailendra, Raj here. Finally,
Yeah.
my technology pains are over. While we are talking about technology, we have to deal with this technology. And Rajesh, fantastic, insights of that. A few things I want to chime in here is the new world a couple of things, designations or positions in the organization is Chief Data Officer. We never heard about this. Chief Data Officer, Chief Data Steward. These are the new roles which are emerging in the companies. And very interestingly, I was participating in a conference with the industry management people. And what I saw was, who is the person, after the CEO, CFO or somebody, who is responsible for the assets in the organization? And whenever it was talking about assets, people were talking about movable, immovable, all those kind of assets. Today, organizations are very cognizant. They are investing time and money on the assets of data. But what they realize is the other physical assets, whether it's a building, plant or machinery or anything, can depreciate. The only asset which doesn't depreciate and it appreciates is data. And CEOs, the CX suite is investing on harvesting and harnessing the data. And the data is becoming the new currency, which is giving them the difference between an organization which is able to see into the future and able to predict and prescribe what should be done in the future is the organization which has harvested and managed its existing data. A data is as should be preserved and harnessed as much like a plant and machinery or a distillation column or a car, like just any other asset. These are the two things, how data has to be seen in this new world. And that's going to be our fuel to drive our new generation economies and new drive business. And Shailendra, I believe there were some questions for me. Can you just tell me the questions which I need to answer?
We'll come back to that, Raj. Let me just go to some other questions. Sorry.
There is an interesting question that the audience have voted. So in terms of the apps, they want to know whether they are used philanthropically or commercially, especially in relation to data ownership. Do they use the data for any commercial purposes?
Yeah, okay. I'll take that question. We are a startup, number one, and startup gives us the flexibility and the independence of doing things the way we want, because we are not a monolithic large organization. That's number one. So at least in the case of Healfa, we have said that we are going to create an ecosystem, an environment where people can join the platform, and we will have got an effect. To have an effect, to answer your question binary, yes, our app for the social segment, for the community. For example, Healfa has been serving the social segment on pro bono basis, on cost basis to some organizations, and we do 50% of our business comes from our paid customers. The paid customers are the ones who give us enough fuel to penetrate into the organization and the community and do the social work and the non-NGO kind of a work. Evangeline?
Raj, I think she is asking whether your data is being commercialized.
Yeah, that was the next
that
part
was
of
a
the question.
Okay.
Our data is not commercialized, it is health data. And if I write a prescription, it is between me and the patient. That is it. And my colleague doctors will be able to see my prescription only if my patient allows them to. The investigations that I have prescribed will be visible to me as the prescribing doctor and the patient who has got it done, but to none else, unless they enable it. So there is data privacy. Data is not used in that way. But when we are doing healthcare checkups for schools and all, we do give the school management an idea about, let's say we have screened an entire school population of children. Suppose they are having a lot of caries tooth. Then we do give that this percentage of your kids have caries tooth problem and they need a dental support. So your school has to invest in this. Or suppose a lot of them have astigmatism, then we give it to them that so many percentage, but it does not tell who in their class is actually having that problem. Okay. So it gives you, suppose you have a class where a lot of people are having a high BMI. It tells you that so many people are having a high BMI in your school. You need to invest on your physical training classes. You need to have more games periods. But it will not tell who in your class is having a high BMI. So data is used in a particular way, but not harvested and sold or commercialized.
Yeah, no, that makes sense. Thanks for answering the question, Dr. Vijay. Just to follow up, so is that when you said the patients have the option of whether sharing it to other medical practitioners or not, is that on an opt-in basis or an opt-out basis? What's the default?
It's an opt-in basis.
I think it's an opt-in basis, okay, not an opt-out.
Yeah, yeah.
It's an opt-in basis.
You have to opt in to share it. You can't, it's not a default option of opting in. The opting in is a specifically to be done task.
Okay, no, that makes sense. I guess another related question is what has been shared about, being able to bridge that gap and increase accessibility between patient and doctors, that's great. But to kind of see things from the other side of things, what happens if, because the patient can choose to opt in, whether or not their information is shared with other health practitioners. Say if a patient is wanting more drugs than they're allowed, how would you sort of rectify that situation? So other health practitioners...
There's a problem here. There's a problem, I think Rajesh will understand and many others will. Yeah, not all medicines are regulated strictly. You can get medicines across the table, OTT medicines, and also prescription medicines very easily. It's not a very strongly regulated market, though in theory it is not to be given. The only drugs which are not available across the board are the narcotics. Except for the narcotics part of it, like prescribed narcotics, morphine, codeine, all those things, except that segment. Even higher antibiotics, injectable antibiotics can be made available across the counter without any prescription. It's easy. So in India, it doesn't make great sense for us to restrict a prescription. Though there are rules saying that this prescription can be renewed once only if the doctor says that, those rules are in place, it's not yet implemented. But for the narcotics part, it's very strictly implemented because the person who sells those narcotics is responsible for any deviation.
Yeah, no, that's very clear. Thank you so much.
To add on, what happens in many of the advanced countries as well, if you have a physical paper prescription, for example, and you go to it's prescribed by a doctor and an authenticated hospital, you go to pharmacy number 1 and you will get the medicines. But the pharmacy number 1, after giving the medicine and the receipt, does not say I have issued and you cannot take it from another. You can go to the next pharmacy, pharmacy B and pharmacy C, and continue, whether it's Europe or the US and many advanced countries, it doesn't matter. Prescription is, they look at the prescription, but they don't see how many times the prescription has been issued against that. So those digital records nationally are not available. There's a lot of work to be done. Most of the governments and the policymakers are making it. They're making an effort. In terms of India, India is trying to get everyone onto the health record, the National Health Mission and the national data, the national policy, the digital policies are getting stronger, and that's moving. We saw that earlier it used to take 5 to 10 years to make a policy change, but these days the government is pretty agile, not only in India, many parts of the world. People are changing policies much more swiftly in months. That's a very good thing. They are moving with the industry, academy, and the institutions.
Thank you.
Okay, so I think with this we have covered most of the questions. There are a few very detailed questions, not details, pointed specific questions. For example, are these apps paid or free? I think we've covered that. How long it takes for people to be used to these apps? I think Raj, you covered it for your bit when you were presenting Hilfa. So I'll just skip those questions. I'm just looking at some of the topics which we wanted to discuss. I think we've covered most of it. From your side, Evangeline, Dr. Deepti, is there any topic you wanted to cover while I'm just skimming through all my notes here?
No, I think we've done we've covered a lot of ground, Shailendra, and thanks very much to the team. So I'll hand back to Evangeline to close the webinar.
Yes, once again, thank you so much for all of our speakers for spending the time to really go through with us what has been happening in the technology sphere in relation to healthcare. I've learned a lot, and I'm sure that a lot of our audience here, including those that will be watching the recording, will learn a lot as well. So thank you again. Now, I just wanted to give a quick plug on our upcoming webinar, which is next week on the 22nd of September. This webinar will be delivered by Professor William Rawlinson, and the title will be on diagnosis and characterization of SARS-CoV-19 and variants of concern. This will be an exciting topic, so if you're interested and if you know anyone else that is interested, please get them to hop over to this link here to register for it. So that'll be next Wednesday, the same time, same place. And just again to remind you, so this event is organized by the ANU COVID-19 Peer Support Program. If you want to learn more about what we do, please feel free to visit this website. Importantly, if you would like to register as a volunteer, or if you like to seek specific expertise advice, please also email us, and we'll be more than happy to initiate that contact. Okay, so thank you so much to everyone for joining our event tonight, and thank you to all of our speakers for spending your time with us. I hope that you have a good rest of the day. And for our speakers, I'll ask you to just stay online for the moment. We just want to take a quick group picture, if that's okay with you.
Yeah.
And a special thanks to all the panelists who have taken out time, our stakeholders who have agreed to spend their time and share their perspective. Thank you, Rajesh. Thank you, Ahmed. Atul,
Yes,
Rama.
that is right. Especially, yeah, we have such an international panelists. For example, from David, who is streaming all the way from Paris. So thank you so much. Yeah. Okay. If it's possible, can I ask all of our team to switch on their video? Thank you, including Amit and Rama, if it's not too inconvenient. Okay. Maybe they're busy doing something. All right, that's fine. So is everyone okay with me taking a photo for social media purposes? Thank you very much.
I'm fine.
So,
David, are you good?
Thank you, everyone. Thank you, Dr. Vijay. Thank you, Dr. Deepti, for setting up this platform.
Thank you for spending your time and effort. Really appreciate it. Thank you all.
Thank you.
Thank you, everybody.
Thank you, team. Bye-bye.
all right, that's all good.